Thank you once again, and a wonderful meeting organized by RIC and RIC organized by Dr. Unni and his entire team. I also feel now more like a fellow. I've seen MACTEL when we started diagnosing them 25 years back, around 25 years back, and I still learn a lot more every year. So I think we are all students. I look more like a fellow now. So we are primarily, all the evidences point out to the loss of Muller cells as the central pathological process, and these are like the pillars in the architecture. And this detection has been due to certain other clinical and histopathological observation, wherein they found that depletion of luteal pigment is one of the signs that they see, and that's primarily because Muller cells serve as the retinal reservoir for the xanthophyll. And the postmortem histology showed region of macular pigment loss correlated well with Muller cell depletion, and the markers of the OLM were lost where Muller cells were lost. So in the studies that have been done, they've actually looked at it. Now, we all see that when there is loss of Muller cells, there is a collapse of the retinal architecture, and that leads to an optically clear space, just sparing the ILM. So it just looks as this picture that you see here on the B scan. So here is another patient in which you see these changes that occur due to loss of Muller cells in the early stages of MACTEL. And this, now one can see that there is some ellipsoid zone loss, which is the next change that you see, but possibly induced by the Muller cells, which go on to the rods predominantly. And the postmortem studies with electron microscopy and immunohistochemistry showed that there is debris in the subretinal space due to reduced outer segment phagocytosis. This results in the consequent loss of photoreceptor inner segment, outer segment junction, predominantly in the non-central area to begin with, and then proceeds to the central area. And it best correlates with the visual function. So here you see that it starts in the non-central area in the early stage of a MACTEL. So one can see that it starts here, and then one can see that this patient had a typical non-central with some amount of tissue contraction, and in later stages it goes on more to the center, and in more advanced stages one can see that there is a lot more now involvement of the entire central process, and there is a collapse of the retinal architecture. So there is thinning of the fovea, and there is resultant pigment migration, which one could see here that the pigment starts migrating, and which becomes more pronounced as the stage advanced, as in stage 4. So this is how the course goes. Now this, in addition to it, there is tissue contraction in the temporal retina. So the Muller cell loss is followed most likely by the remodeling with inflammation and cell migration. So a common sequel of healing is tissue contraction causing angulated vessels. So this results in angulated vessels that we see clinically. And there is abnormal vascular anastomosis in this condition, which begins temporally. So one can see that there is telangiectasia and the abnormal anastomosis that are observed initially, which go initially from the superficial area and goes deeper with time as the stage advances. And the neovascularization, so once you see a right-angled venule, generally one associates with neovascular process. So this is what we see when we do an OCTA. This is a patient who had a right-angled venule. One can see that this right-angled venule. And this, when you see on OCTA, shows in the deeper plexus, one can see that this right-angled venule has a change that occurs here, which then, as you go deeper, you can see that there is the neovascular complex that occurs. So these are the various changes one can see, and on following treatment, one can see a regression of that neovascular complex. So this is a study by Richard Spade, which looked into a patient from 2009 to 2016, and shows the various stages that they have gone on, to start with the loss of the Muller cells, with the collapse of the tissue, the loss of the ellipsoid zone in the non-central area, which starts progressing towards the center. There is tissue contraction in the temporal part of the macula, and that leads on to change in the architecture. There is a lot of contraction of vascular, all the blood vessels. There's a right-angled venule, which then leads on to the neovascular process starting superficially and going deeper. So all these processes are generally due to the initial trigger that starts with the Muller cells, which trigger all these processes to occur. So MACTEL is characterized by a Muller cell loss, which is then accompanied by, possibly as a consequence to it, is the ellipsoid zone loss. And the vascular changes occur secondary to tissue contraction, which occur as a healing process to this Muller cell loss. I think that's the primary defect, is the Muller cell loss. Thank you.